Hello, and thank you for joining us. I'm Dr. Fred Cass, Director of Medical Oncology at Ridley-Tree Cancer Center. Our physicians and staff provide comprehensive cancer care using the most advanced treatments and technology. But our role in the community extends beyond caring for our patients. Our community outreach programs improve public understanding of the diagnosis, management, and prevention of cancer. Our community lectures discuss current topics in cancer care and prevention. As part of our commitment to keeping our community safe throughout this pandemic, we are offering this program virtually. I'd now like to introduce Dr. Charles Conway, surgical oncologist at Ridley-Tree Cancer Center. Dr. Conway's practice focuses on the multidisciplinary care of patients with gastroesophageal, hepatic, and pancreatic tumors. Today's lecture will discuss risk factors for pancreatic cancer, screening methods, and treatment with a focus on surgical therapies. Please enjoy the program.
Hi, my name is Chuck Conway. I'm a surgical oncologist here at the Ridley-Tree Cancer Center, and I'll be speaking today on pancreatic cancer. Thank you for joining us. We're doing this as a recorded session rather than with a live audience. And I'd also like to thank the Wolf family for providing the venue for this lecture series. So I'm going to talk about pancreatic cancer. As a little overview of the discussion, I'll talk a little bit about some background information on the pancreas itself, incidence and survival of pancreatic cancer, and then the bulk of the talk will be about screening, diagnosis, and treatment for pancreatic cancer. So just very basic, the pancreas is an organ that sort of sits in the back of the upper abdomen. It's sort of right about this level. Actually sits right up against the spine, so it can be injured in traumas, either bike or car accidents. It's intimately associated with the bile duct and the first part of the small intestine, the duodenum. The bile duct actually goes through the pancreas, and we'll see why that's important a little bit later. Its functions can be broadly classified into two, exocrine and endocrine. The exocrine function is such that it makes enzymes that are used to help you digest fats and proteins. Endocrine function means that it basically makes hormones, the most important of which is insulin, but it does make others as well. There are a lot of different tumor types of the pancreas, but I'm going to specifically focus on adenocarcinomas, which come from the cells that line the ducts of the pancreas. And it is the most common type of cancer that we see in the pancreas. The incidence of pancreatic cancer, it's actually relatively rare when you compare it to the more common cancers like, say, breast or prostate cancer. In 2020, it's estimated there will be around 57,000 new cases of pancreatic cancer. And you can compare that here on the slide to breast and prostate. Breast, it's estimated almost 280,000 new cases in the US this year, and prostate, over 190,000. The survival rate is not nearly as good, though. In 2020, the estimated deaths from pancreatic cancer are over 47,000, which is actually more than either breast or prostate at 42,000 and 33,000. So you can see it's much less common, but actually more deaths from this disease. On the upper right on the screen there, you can see the relative 5-year survival rates compared to other tumor types. And you can see for breast and colorectal, much better. And pancreas at 9% is a difficult disease to cure. Traditionally, there hasn't been as much funding for research in this disease, and fortunately, with some efforts from the Pancreatic Cancer Action Network and some other advocacy groups, this has changed, and there is much more funding now. You can see on the lower slide on the right there, and that has somewhat correlated with the improvement in survival. So hopefully, with renewed interest in research in pancreatic cancer and funding it, we'll continue to see that number rise. One area that I think we're actually doing a little bit better than some of those statistics reveal is in removing precancerous lesions. So we now know that there's certain cysts of the pancreas that will become a cancer or are high risk for becoming a cancer if you don't take them out. And essentially they're the mucinous cysts, so cysts that make mucus. the lining of those cysts can become pancreatic cancers. You can see in this picture the two different types of mucinous cysts, or the mucinous cystic neoplasm and the IPMN, or the intraductal papillary mucinous neoplasm, IPMN for short. And both of those do have a cancer risk. I recently took care of a 56-year-old gentleman who had pancreatitis, and when we did the imaging of his pancreas, we saw one of these precancerous cysts and ultimately offered him surgery. He did well, had a Whipple procedure that I'll talk about more later. And he did have what we call high-grade dysplasia in his cyst, which essentially is cancer that hasn't invaded into the pancreas yet. So the cells lining the cyst had become a cancer. So I think that should be considered a cancer cure, but it won't be counted in the cancer statistics. So in some areas, I think we are doing a little bit better. Pancreatic cancer screening is sort of taking off a little bit now. There's a group, a consortium led by the Johns Hopkins group called the Cancer, the Pancreas Screening Consortium. And essentially it's a group of physicians and scientists that are interested in this to get together and review the data and make recommendations. There's a lack of large randomized controlled trials, so essentially it's sort of reviewing cohort studies and what's happened with groups of patients. And the lifetime risk of anyone getting pancreatic cancer is about 1.5%. So it's too low to just institute a general population screening measure. So instead, what we try to do is identify high-risk patients. And it's felt that if your risk is above 5%, that you would be considered high risk and should consider screening. The way that we figure this out is through either just a family history where the patient is just asked about relatives that have pancreatic cancer, or through actual genetic tests. There are some genetic abnormalities that we know are associated with increased risk of pancreatic cancer. Of the patients with a familial susceptibility, though, we probably only know about 10% of the reasons they have this increased risk. So still, the family history is really important. The goals of a screening program, sort of like any cancer screening program, is to identify patients at high risk, and then hopefully in them identify tumors when they're either precancerous or extremely early in the process. The precancerous lesions for pancreas would be like I talked about with the mucinous cysts. Sometimes even with these screening programs, we pick up other tumor types like neuroendocrine tumors. And then if they do already have a cancer, we try to catch it where it's within the pancreas and less than 2 centimeters, and hopefully not in the lymph nodes, because those are potentially curable points in the progression of the tumor. The recommendation currently is that anyone with 2 or more blood relatives with pancreatic cancer, and one of which is a first-degree relative, should undergo screening. So that would increase the risk that the person would get pancreatic cancer to about 5%. Essentially, these charts are made just by asking patients or family members who in the family does have pancreatic cancer or other cancer types even. And then a chart is made to help decide what the risk might be. If you have 2 first-degree relatives, the risk is almost 10%. It's extremely important that patients with pancreatic cancer are referred for genetic counseling. This will allow reviewing patient history in detail to see if other members of the family should be counseled or even have genetic testing. And it'll also allow for the patient to consider genetic testing after they have a good discussion with the genetic counselors to see if they want to move forward with that. But absolutely vital, should be done for everybody with pancreatic cancer. Besides folks with a high group of family members with pancreatic cancer, if someone does actually have a mutation in their genetic makeup in these particular mutations, they also should get screening. And these are mutations that we know have an increased risk of getting pancreatic cancer. And again, absolutely vital that genetic counselors are involved in the care of these patients. Hereditary pancreatitis, where folks get pancreatitis at a very early age, sometimes even while they're young children does have a high risk of pancreatic cancer, up to 40% in some studies, so that those folks also should get screening, and then people with Points-Jaeger's disease should get screening. So once we've identified someone who we think is at higher risk, either through their discussion about their family history or if they're a known mutation carrier, then we would set up some sort of imaging study. And the two imaging studies we use are MRI and endoscopic ultrasound. The pictures on the right are an MRI on the top and an MRCP on the bottom. You can actually see the ductal system with the MRCP. And then on the top, you can see an actual mass in the pancreas that's being indicated by the yellow arrows. The MRI is excellent because it doesn't give any radiation to the patient. CT scan would use radiation. And the MRI allows us to do multiple scans over what can be a very long lifetime of surveillance. The other modality that we use quite a bit is the endoscopic ultrasound. I'll talk a little bit more about it later, but it's extremely vital in the screening process. And the real benefit of endoscopic ultrasound is that it allows you to actually do biopsies of any mass you may see in the pancreas. And also, if there's a cyst, the cyst fluid can actually be aspirated and studied to see if it is a higher risk lesion. It's also important to remember that pancreatic cancers can alter the blood glucose control of patients. So if you have a patient that's in their 60s or 70s and develops worsening diabetes, then that needs to be a bit of a red flag to see if there is some sort of problem with the pancreas and potentially a tumor growing. It's recommended by the CAPS Consortium that screening in high-risk patients starts at 50 or 55 or 10 years before the youngest family member with pancreatic cancer. For those with a mutation of CDKN2A or Points-Jaeger's disease, should start at 40. And if you have other mutations, it should be started at 45 or 50 or 10 years before the youngest family member with pancreatic cancer. If no concerning findings are found on the MRI or the endoscopic ultrasound, then screening can be done annually. If there is a concerning lesion identified, then it should be done every 3 to 6 months. And essentially what we do is alternate the endoscopic ultrasound and the MRI for every other test, because the endoscopic ultrasound is an invasive test that does require anesthesia. And then if you do find something on the imaging, a high-risk mass or a worrisome cyst, then that would be an indication to consider surgery. So moving on to how we diagnose patients with pancreatic cancer, just a little bit about how the patients tend to present to us. A lot of times with pancreatic cancer it can be sort of nonspecific, and folks will a lot of times just say they don't feel like eating, they're losing some weight, they've lost their energy, and just kind of don't feel themselves. It depends a little bit on where in the pancreas the tumor develops. So if it develops on the right side of the pancreas where the bile duct is, a lot of times they'll develop jaundice relatively early. Whereas if it develops in the tail of the pancreas on the left side, you can actually get significant progression of the tumor without a lot in terms of symptoms. When a more later stage, you can actually get things like fluid in the abdomen and bowel obstruction. And again, like I mentioned, new or worsening diabetes in the right demographic is worrisome. Sort of the cornerstone of making the diagnosis and working up folks who we suspect may have a tumor in the pancreas would be the CT scan. And this is a picture of the CT on the right side of the slide there. And you can see the tumor sort of in the middle. It's sort of the hazy area near the blood vessel. But that would be something that we would use and be able to see nicely what's going on in the pancreas. We also sometimes use MRI and MRCP like I talked about earlier. And then there is a tumor marker for pancreatic cancer, the CA19-9. It's not specific enough to be used widespread, but we use it in patients we have a high suspicion to help confirm. And then also it can be used to monitor treatment and see if the treatment is working. And again, the glucose levels need to be watched. A little bit more about endoscopic ultrasound, because I think it is so important in helping take care of these patients. Essentially, it's a scope test like you'd get to look for an ulcer. Does require anesthesia. The scope is passed into the mouth, down the esophagus, and into the stomach. And there's an ultrasound probe on the end of it, which can be used to get really nice pictures of the pancreas, and then can actually be used to guide a needle into a mass or even a cyst to get a good sample for the pathologist to help decide if that's a cancer or not. I'll move on to treatment now. Kind of the main treatments that we always think of with pancreatic cancer are surgery, chemotherapy, and radiation. It's so important, though, to remember that those aren't the only things to help with the patient. Sometimes there are significant pain issues that need to be dealt with. Nutrition and fitness are incredibly important. Because this tumor affects digestion, people can easily lose their fitness because their nutrition can become poor, and dietitians often need to be involved right away. And then also, a lot of people have significant anxiety and depression over this. I mean, this is a very scary diagnosis, and the mental health and wellness really has to get as much of a priority, I think, as considering surgery and chemotherapy. Everybody with pancreatic cancer really should be assessed by a multidisciplinary group in the setting of a tumor board, where the imaging is reviewed, the pathology, and then the various specialties, medical, surgical, radiation oncology, gastroenterology, and the radiologist and the pathologist can review all the information. And then the treatment decision can be made really as a group. The decision really shouldn't depend on which specialty the patient just happens to see first. It really should be a group consensus. One of the early things that we try to sort out is whether or not surgery is a possibility for the patient. And essentially, you need three things to be able to have surgery for pancreatic cancer. The first is that the patient needs to have reasonable performance status, which basically is just a way of saying they need to be fit enough to sort of take it on. And it doesn't really mean that, you know, they have to be doing a lot of long distance running or anything, but just to be able to, you know, walk a couple of blocks, go to the store and get something if they need it. But you certainly need a certain level in order to be able to take this on. And then also the nutrition factors are vitally important. If people are malnourished, they really do very poorly with surgery, and that needs to be fixed before you consider doing a complex operation. The second thing is that you need to make sure that the patient doesn't have any distant spread of their tumor. So if somebody has a pancreatic cancer and it's gone to the liver or the lungs, taking out the tumor in the pancreas really doesn't help. It just puts them through the risk of the surgery without any significant benefit. And so we make sure we get scans of pretty much the whole body before we'd embark on that. And then finally, the thing we look at is sort of the local extent of the tumor. And in the top slide, it's a CT scan of someone with a pancreatic cancer. And the tumor is right next to that white circle, which is the stent in the bile duct. But it's so small you can hardly even see it. Whereas on the bottom, the tumor is the gray area that's surrounding the white dot in the middle. The white dot is actually the main blood vessel that goes to all of the intestine. So very different picture, where in one you can hardly see the tumor, it's so small, and then the other one is actually encasing a very important blood vessel, and we wouldn't be able to take that out. So performance status, no spread, and importantly, we have to look at the local extent of the tumor. The different surgical procedures, the most common one is called the Whipple procedure, and I'll describe it a little bit more later. That would be for somebody with a tumor in the head of the pancreas, like we see here in this picture. The tumor is circled with the red circle. And then if the tumor is on the left side of the pancreas, in the body or the tail, sometimes we can just do what we call a distal pancreatectomy. Very rarely we take out the whole pancreas. Not done very often for cancers, but every now and then in the right situation, we may offer that. The Whipple procedure is sort of depicted here. On the left side of the screen, it sort of shows the specimen being removed. That's the head of the pancreas. The green is the bile duct, and then the pink is the duodenum, or the first part of the small intestine. The gallbladder is also there, sort of hanging off the bile duct. A lot of patients will have already had their gallbladder removed, but certainly if it's there, we do take it out. And then the right side of the screen, you see the reconstruction. So we have to reconnect to the green bile duct. We reconnect the pancreas also to the small intestine, and then we reconnect the stomach. That allows patients to be able to eat again, and then also for the bile and the pancreatic secretions to be able to help with digestion and absorbing their calories and nutrients. Early on, this procedure was associated with what many would consider a prohibitively high mortality rate. These are 4 different early series of Whipple resections, and these are actually fairly well-known names in the world of American surgery. And you can see on the far right column, the mortality rates are really quite high, 12 to 18%. And there was a time when a lot of medical professionals actually wondered if this procedure should ever be done. Fortunately, though, we've gotten a lot better at it. And essentially, it comes down to standardizing the procedure and then doing it routinely enough that you essentially get better at it with practice. This graph shows mortality data grouped by different procedures, and then also each little bar correlates with a number of that particular procedure at the hospital. So you can see for colon resections and stomach resections or gastrectomy, the bars are all essentially the same. So doing more of the procedure in the hospital didn't really reduce the poor outcome. But you can see that removing the esophagus or removing the pancreas pretty clearly, when you did it more often, you were actually quite a bit better at it. And in this particular case, the cutoff was 16 pancreatic resections a year. The Leapfrog group is a group that looks at hospital safety data, essentially, and is available for consumers and patients if they want to decide where they want to get their health care based on safety outcomes. And they have put together what they feel are minimum hospital and surgeon volume standards for different complex procedures, one of which is pancreatic resection. And they recommend that you have this done at a hospital where more than 20 cases are done per year, and a particular surgeon does more than 10 per year. These are our numbers at Cottage, and since I've been here, we have been able to get over this standard. The first year I was here in 2018, we did 22, 24 in 2019, and this year we should go over 30. So I think we can do it as safely as anywhere here with the great team we have here. The way that we're able to improve the safety and outcome of this procedure is really by standardizing everything all the way through the continuum from the initial meeting and figuring out the patient has pancreatic cancer through the postoperative recovery period. And it really does take a village of people to be able to do this. In the beginning, we make sure the patients are fit. Sometimes we do put them on a prehabilitation program where we actually try to get them stronger and more nourished before surgery. The surgery and the anesthesia team needs to be know how to do this well and know the particular details of this type of complex surgery. And then in the postoperative area, the nursing getting to know these patients is incredibly important. They really see the patients more than anybody, and they really know if somebody isn't quite recovering the way that we'd like them to, and let us know right away so we can try to get them back on track. We do try to standardize our post-surgery pathways. We do what's called an enhanced recovery after surgery type pathway. And much better than the slide I showed earlier, in high volume centers, the mortality is quite a bit lower at less than 2% across the US. This is one of our pathways. It's kind of a busy slide, but really just to show you that we sort of break up the recovery by day, and then we know, and the whole team knows, the nurses, even the patient, sort of what kind of goals we have for each day after surgery, ultimately on to heading back home from the hospital. The next treatment I want to talk about is chemotherapy. Chemotherapy really is used in almost all cases of pancreatic cancer. It's used in patients with metastatic disease where the tumor is spread, most commonly to the liver or the lungs. It's used in patients who can't have surgery, if the tumor just can't be removed because it's involving too many of the blood vessels. And it's also used sometimes before surgery, sometimes after surgery, and I'll talk a little bit more about that. It can control tumor, it can kill the tumor cells, and it can also even help with symptoms. Sometimes people have pain that will sometimes even get better with the chemotherapy. For a long time, in taking care of these patients, we didn't have a good systemic chemotherapy option. And fortunately, in the relatively recent past, that has changed. We now have a regimen. It's a multi-drug regimen called FOLFIRINOX, which is a combination of 5-fluorouracil, leucovorin, irinotecan, and oxaliplatin. And this is the paper that sort of showed that it was better than what we had been using for many, many years, gemcitabine. And you can see the two curves. The red one is the FOLFIRINOX, the blue gemcitabine. And essentially, higher up and farther to the right is better. And so the survival in patients with spread of their pancreatic tumors was quite a bit better using this newer regimen of chemotherapies. And this was really quite exciting because, like I said, we didn't really have good options for chemotherapy before this. It's then been used in what we call the adjuvant setting. So it used to be very common that we would do surgery and then patients would get gemcitabine afterwards, but now we try to use the FOLFIRINOX afterwards. And again, you can see the red line is quite a bit better. And in fact, in this paper, we really saw survival rates that we essentially had never seen before, with a 5-year overall survival rate around 50%. Really never seen before in this group of patients. The other thing that we do quite often now is actually give chemotherapy before surgery, what we call a neoadjuvant strategy. And there's a lot of different reasons why this makes sense. One is that you can immediately treat the entire patient. It's important to remember that a lot of patients with pancreatic cancer, although you may do a CT scan and only see the mass in the pancreas, there's a good chance that they have pancreatic cancer cells that have gotten away from that mass and are somewhere else, but just aren't big enough to be seen by the CT scan. If you go straight to surgery, all of that is going to be ignored for the duration of the surgery and the recovery because you need to let the patient heal before you do give the chemotherapy. And surgery is a focal treatment. So this strategy, giving the chemotherapy first, would allow you to treat the whole patient right away. It also may help you avoid surgery in folks whose tumors are just very aggressive and surgery was just never going to help. Unfortunately, we do see that sometimes in this disease, and we hate to put somebody through a complex operation if they're not going to get benefit. It may help the resection margin at the time of surgery, giving the chemotherapy first and even radiation. And really important, I think probably the most important, is that it's become very clear that surgery alone is just not good enough. And you really need to figure out a way to make sure the patient also gets the benefit from the chemotherapy. And sometimes when folks get surgery and then try to add in the chemotherapy, they have a really difficult time because they're just not quite ready to take on a significant chemotherapy effort when they just not long ago had a big, somewhat life-changing surgery. And so if you give it after, only about 50 to 60% of patients will actually complete the chemotherapy regimen, whereas if you get it beforehand, almost everybody will. So if you know that it works and it's important in the treatment strategy, I think it becomes really important to figure out ways to make sure that your particular patient can get the benefit of getting the chemotherapy. And then also it allows for some sort of research type strategies. So how do we decide who we're going to offer the chemotherapy first strategy? Right now, for people who are going to have surgery for their pancreatic cancer, we sort of split them into two groups. One group we refer to as resectable, which essentially means that we think that on imaging their tumor is confined to the pancreas. The other group we refer to as borderline resectable, and these would be folks that either were worried the tumor has already gotten outside the pancreas, meaning it's starting to involve some of the blood vessels. You can see that on the bottom slide. The bottom picture on the right of the slide. You can see the white circle again is the stent in the bile duct. which was placed to relieve the jaundice. And then just up and to the right, there's a whitish structure that's sort of pinched into a triangle, and that's what's called the portal vein. And that indicates that the tumor is actually involving that blood vessel. And so it's gotten outside of the pancreas a little bit. The other two groups who would think about this strategy would be if we're worried that the lymph nodes may be involved, which would be another indicator that the tumor has gotten outside the pancreas, or those with poor performance status, meaning they're not quite fit enough yet to take on surgery. Very importantly though, if someone is labeled borderline resectable, it doesn't mean that they can't have surgery. It just means that we think the chemotherapy first option is better. Sometimes I do recommend chemotherapy first to patients, and they get very worried that they're sort of missing an opportunity for surgery, and that's not at all the case normally. Instead, it just means that I think that the strategy should be a little different order, and that the chemotherapy first would be better in their case. This is a study that I was fortunate enough to be a co-author on, but in this particular paper, they looked at patients who were in that borderline group, and they were given FOLFIRINOX and then radiation and then went on to have surgery. And you can see on the bottom left there, importantly, when the pathologist looked at the tumors, they did have a reasonable response rate, and in fact, almost 15% of them, they didn't find any residual tumor. So we are starting to see treatments that really do have a significant effect. So it sort of does leave the question, should we do the chemotherapy first option in everyone? And I think you can make a good argument that the answer is yes, but this is a particular trial that just started, and we're hoping to open it here at the Ridley-Tree Cancer Center, where patients will be randomized to either start with chemotherapy and then surgery, or go straight to surgery and do their chemotherapy afterwards. And this is for patients with the tumor confined to the pancreas, and I think will help us sort out whether or not we should do this routinely. Radiation, just to kind of briefly cover radiation, essentially high energy particles or waves are used to attack tumor cells. The sort of modern day radiation devices allow the radiation oncologist to pretty amazingly focus the beam on a particular area of the body by using multiple beams. And it really allows you to avoid normal tissue. It's really quite fascinating how well they can do this to minimize side effects and really focus. It's a focused treatment, kind of like surgery, but even in the middle of the abdomen, they can focus on a particular area and kill those tumor cells. Has been shown to improve survival after surgery. There's definitely data that it may be helping to do a better job at surgery if it's given beforehand. Can slow tumor growth in unresectable patients, so people that unfortunately I can't take it out because of significant blood vessel involvement. They are candidates for radiation to slow that tumor down. And then also, it actually does work well for pain, so we sometimes use it for pain palliation. I wanted to once again talk a little bit about the support services and how important I think they are, and how essential they are in a pancreatic cancer program. You can't just focus on the tumor. The patients really need to be treated holistically, and issues with nutrition and wellness I think have to get some attention. And fortunately here at the Ridley-Tree, we really have tremendous support services in nutrition, genetics, social services. The navigators help get the patients through this fairly arduous program. There's a wellness program and a resource library. And the Ridley-Tree Cancer Center, the services I think really rival many large academic centers. In fact, we have better services here than the academic center I was at previously. And it's really thanks to the tremendous philanthropic support and the help of the Cancer Foundation of Santa Barbara that I think we have a fantastic program. I do think there are some reasons for optimism in this disease. Although the overall survival, if you look at everyone with pancreatic cancer, still is not nearly where we'd like it to be. It certainly is getting better. The government is putting more money into research in pancreatic cancer. And the 5-year survival overall is getting better. I think we are getting better at surgery for this disease. We can do it safer and have better outcomes. The chemotherapy and radiation treatments are getting better and more effective. And as I said, there's been a renewed interest in research in this area. A couple things that are happening that I think are pretty exciting. There is a significant effort in pancreatic cancer to do precision medicine, and essentially that's giving treatments that are tailored by the patient's tumor. The bottom is the title of a paper that was recently published where a large group of patients, their tumors were molecularly profiled to see which drugs may be more likely to work. And then instead of getting the standard regimens, they received treatments based on the profiling, and they did see some better responses and improved survival. The top two pictures, one is the title and then another are sort of cellular pictures, is a group that's actually making organoids. So they are making small tumors out of the patient's tumor. They grow them in the lab, and then they treat them with many, many different therapeutics, and they just basically look and try to see which one seems to work the best in the lab. And then that potentially could be used in the patient. The limiting step in this has always been that it takes a lot of time to get that information, and you need it right away. But the turnaround time is getting very quick, and scientists are coming up with ways to get that information right away to see which treatments may work the best. I'll just sort of leave with this patient. It was one of mine that I took care of a few years ago, 76-year-old gentleman who presented with painless jaundice. And he did have involvement of the blood vessel. So we started him on a chemotherapy first approach. He actually got chemotherapy and radiation. He had his endoscopic ultrasound and had a biopsy, which showed the adenocarcinoma, and his tumor marker was 151. He then had his treatment. As part of that trial that I mentioned, his tumor marker normalized, and he had a surgery. I did also have to take part of the portal vein and put it back together, but he did well from that, and he had a complete pathologic response. This is the kind of thing that we just didn't see when I sort of first started or when I was in my training. So our treatments are definitely getting better, and I think they'll continue to improve. So again, thank you very much for taking the time to listen. Hopefully it was worthwhile. Certainly feel free to reach out to me at my email here if you have any questions. And thank you very much.